is Joe.
Thanks for having me.
If you want to introduce yourself and tell us what you do.
Sure, I am Dr. Danielle Plumber, and I'm a pharmacist in Las Vegas, but not your traditional pharmacist. I did start there, and now I'm involved in many different projects using my clinical education.
And what brought you to Vegas?
So my parents moved here many years ago. My father's now a retired pharmacist, but I grew up in New Jersey, and at the time, my parents wanted someplace warmer and a lower cost of living, and looked south, looked west, and chose Las Vegas, so I followed them out here.
So several pharmacists in your family?
Actually, yeah, my grandfathers were both pharmacists as well. And fun fact that my maternal grandfather was actually the last pharmacist in the state of Connecticut to become one by apprenticeship, the 1940s. And I just think he's amazing. He's watching me from above that I had to go through many years of schooling in a big, deep student loan debt to get my degree, but it's been worth it, absolutely.
That's a pretty cool legacy.
Yeah, definitely.
So what made you want to become a pharmacist? Was it partially because it was in the family and maybe a little bit expected, or did it also have a natural curiosity towards it?
Not expected, definitely natural curiosity. When I was a teenager, I used to work in my father's store and always knew someday I'd grow up and become a pharmacist. Life took me in many directions and then brought it back full circle. So I got my PharmD about almost 6 years ago now.
Okay. And what level of schooling is it for pharmacy now?
So pharmacy now is a doctorate degree. It's literally PharmD, P-H-A-R-M-D for Doctor of Pharmacy. But the length of the program varies by what pharmacy school you go to. The one here in Las Vegas, I did not attend, but that's a 3-year condensed program. I went to a 4-year program, but many pharmacists now, and that's after you have your bachelor's, many pharmacists now go on to do residencies, either 1 or 2 year and fellowships. And/or fellowships.
Okay. And you're a little bit different than a traditional pharmacist. So what are some of the other things that you're into?
Oh my gosh, it's amazing. So I fell into a position that's now a business on its own, and it's working with pregnant women who have extreme nausea and vomiting during pregnancy. There's so many wives' tales that are and fallacies that are that these women are told, like, it's normal, it's okay to be sick, it'll go away at 12 weeks, and they're not offered medication or not taken seriously. And that said, all medications have many adverse effects and many risks, and there are no FDA-approved medications for this extreme disease state called Hyperemesis Gravidarum. So that's kind of what I've fallen into. I've obviously had this myself through my pregnancies. It was before I got my degree, and it was in pharmacy school that I learned you can feed people who can't eat? Like, how come I didn't know this? No one ever talked about nutrition. No one ever talked about physical movement. You are both physical therapists, and I was talking to your colleague here, Antoinette, and she's saying when women are on bed rest, or in the case with women with this disease state, you're stuck in bed for a very long time because you literally don't have the energy. You're malnourished, you're dehydrated, your electrolytes have plummeted. And there's ways that she was telling me that you can keep your muscles strong, which is amazing. Nobody discussed any of this. So now that is a business on its own that I do. I have a full-time job with a company that works in biomarkers. My line is called procalcitonin. And did you want me to talk about that right now?
Yeah.
Okay. It is a blood draw, and it tells what type of infection you have. It goes to very high levels in the presence of a bacterial infection. So if you're in the hospital and you have all these other inflammatory markers, like you have a fever, you have white blood cell count, and the doctor wants to give you antibiotics, we can use this test, not as a standalone, but as a series in conjunction with your clinical presence to see, should we be treating you with antibiotics? So you want it when you go into the emergency room. And then if you do get admitted into the hospital, they're going to do the test. Again, it could be 12, 24, 40, 72 hours later, and see if the levels are going up or coming down. And based on that, we'll know if it's the right antibiotics you're on for the infection. Right now, it's FDA approved for sepsis and for lower respiratory tract infections. Hopefully soon it will be approved for pediatrics as well. And in other parts of the world, it's used outpatient. So hopefully sooner rather than later, you can go to your doctor instead of, with a sinus infection or whatever, instead of saying, here's a Z-Pack, we can say, hey, let's do this test first and watch your symptoms and then decide if we should give you antibiotics or not. And it's just really important because the overuse of antibiotics around the world has led to antibiotic resistance. And now we have infections that we once had antibiotics for that are now not responding to the medication. And adverse effects of antibiotics can be awful. And if you are admitted, then the length of stay in the hospital as well, shown to decrease the amount of stays. So the financial implications, what we call health economics, is vast as well. So that's my day job. My brain is always working. And what you two reached out to me originally, what we talked about was a completely different science, but it all does intertwine with health and medications. And the whole science is called pharmacogenomics. And it's looking at your whole genome to see how your body will respond on a personal level. The test is called a pharmacogenetic test. And we can look at that to see if you take medications, if you're going to actually have if it's going to be effective in you, or if you're at a higher risk of adverse effects from it. And it can be then used to guide medication therapy for many disease states. And the big ones it's used for now is oncology. So anyone with cancer, we can use it to guide your medication therapy. Mental health is a big one where it shows great use of. And then pain management. And I'm missing a big one right now. I can't think off the top of my head. There's many different ways. And I've been able to use that for my women with this extreme nausea and vomiting. For example, the medication Zofran, the generics on ondansetron. A lot of women say, I don't want to take medications while I'm pregnant. So we can look and go, well, let's do this test first to see if it'll even be effective in you as well. And we're just still waiting to get insurances to cover it for that, but they are covering it for other disease states. Oh, cardiology. That was my other big one. Cardiology. So if you have any issues going with your heart, then we want to look at the pharmacogenetic test results as well.
How long have they been doing that kind of testing where they're specifically pairing it with people's genes?
So it's been around, I'm thinking, for about 20 years, but it was just the last 5 years or so that it became financially viable for the regular person to be able to go ahead and do it. Insurances do cover it for some disease states, and Medicaid, I want to say in about half the states of the U.S. will cover it. Nevada is not there yet, as far as I know, so fingers crossed that Nevada Medicaid will start covering this test soon because it's so important. So in the past, doctors would prescribe medication. I'm not an MD, so I am speaking on behalf of a profession I'm not part of, but based on how they were trained in med school, maybe what the pharmaceutical rep said, the clinical studies. And then a lot of times now, medications prescribed are dictated by insurance companies. So we're going to look at what's on the lowest tier of your formulary, where say you need a statin. One might be a $5 copay, one might be a $50 copay, and one might not be covered at all. So we're going to go with the one that's the lowest copay, of course. But now we can look at this and say, hey, let's prescribe based on what's safest for your body.
So how do they go about collecting the data to know what medication would pair with what type of gene that they find for somebody?
So we have raw data. There's translational software. AI and computers make it very easy, but then you want somebody with the clinical knowledge who's trained. The report comes back about 35 to 40 pages. Your genes don't change. Now, I do believe in epigenetics. Maybe there's ways to turn them on and turn them off, but once that test is done, you only ever have to have it done once in your life. And there's I think like 55 genes right now we're looking at. Don't quote me on that number. I'll fact check that one. And it correlates to hundreds and hundreds of medications. There's many different labs around the U.S., for that matter, around the world that are doing it now. And I think you're going to see more and more of them, and you're going to see the price continue to come down. And in the past, there was a lot of variability between different labs. If they're looking at one pathway or many pathways, I'm going to go back to my example of ondansetron, our medication that's an antiemetic to stop you from vomiting, hopefully if it works well. Very common in oncology again. But it follows many pathways, and there's many metabolites. So when you take that med, how it goes through your body, there's different ways we can absorb it. We can take it as an orally disintegrating medication. We can take it as just when you swallow whole. We can get it as an IV medication. So as it goes through the body, we want to know how are you going to respond to it. Different labs were looking at it from different ways. And now over the years, we're getting much more consistency. So you should get the same results regardless which lab you go to.
I love that. I'm going to touch upon how detailed this report is. So you like casually say it's like 35 pages.
Yes.
It really is, front and back actually. But I want to use maybe an example, and I'm going to talk about what I kind of hear from people, like, oh, Aleve doesn't work for me. Only Tylenol, only Advil. Let's use that kind of as an example for like a pain management, where some people will, take medications for whatever reason, and there's a time and place to do that. Tell us about what maybe you would look at in that realm of how you would look at that test to see how somebody would respond to that.
Perfect. The big one in pain management are opioids. We have a horrible opioid epidemic in the United States right now. So before anyone's prescribed any type of opioid, and there's a right time and place for them, absolutely. So we want to see if you take, say, codeine. Codeine gets turned into morphine in the body. If you're what we call an ultra-fast metabolizer, that's going to happen too quickly. You're going to end up with too much morphine. And not only is it going to work on your pain, but it's going to work on your respiratory tract, and you're going to stop breathing, or your breathing is going to slow down. And that's why I'm going to throw a side note. Everyone have Narcan. It's available at any pharmacy. If you get an opioid, get your Narcan. Know whoever is going to be with you knows how to use it. And in the past, codeine was given to children. Did you ever see where those ads from the early 1900s, and it's like, cough syrup, stop your cough, and they'd give it to even babies, and it turns out it was codeine or morphine, right? So we don't do that anymore. Why? Because children have died, unfortunately, from this, and so now we have this test that's a cheek swab. It's easy to do, and we can say, okay, this one, you're an ultra-fast metabolizer. There's 4 levels. You could be a slow metabolizer, which in the case of codeine, because it's what we call a prodrug, it has to turn into morphine before you can get the effect of it. If you're slow, then you might not get the effect of it. But if it's not a prodrug, I'm going to step aside and use my not pain management example, but I was talking about statins, because a huge percentage of our population have high cholesterol. They're prescribed a statin. That's not a prodrug. So whatever you take, we're going to see which one of those variations you have. So one end of the variation is your ultra fast. The other end is slow. And then you have extensive and normal. And from that, we can guide your therapy to see, is it going to work for you? And are you going to have adverse effects or at risk of adverse effects? Like any lab test, whether it's what I talked about earlier with procalcitonin or with pharmacogenetics, we're not going to use this alone. We're going to look at the whole picture, the body, how their other organs are functioning. Kidney disease, a lot of these medications go through the kidney. Same with liver disease, if they go through the liver. We want to say, hey, let's get the safest medication for you based on all your symptoms and how your body works. And pharmacogenetics is one step in that whole process.
Oh, that's awesome. Maybe we'll talk about caffeine, because that's a big subject that some people respond really well to it. Some people, can you talk about, maybe a high versus low metabolism, or how some people might be surprised at when certain medications will affect your caffeine? Go through a little bit of that with us.
Absolutely. Who knew? Birth control. So many women take oral birth control pills. Caffeine can increase the metabolism of that. So, and this is a little bit on a side note as well, but same with how our gut is functioning. What bacteria is in our gut, what's going on, if we have healthy bacteria, if we take antibiotics and we kill good bacteria, all that comes into play with caffeine and with the other medications you're taking.
So based on that study, how would you use those things and maybe dose, like, okay, I can only drink a certain amount, or like I'm not going to drink any at all? Like how would you use that kind of in a daily life example?
Consistency is really big. So if you always have it with caffeine, so your body always is absorbing the same amount. I think everyone, jumping topics from caffeine, but everyone's heard, I think at this point, of grapefruit interacting with statins. Mm-hmm. This was actually, as it was supposed to be a control group in a clinical study, and they found out all these medications, they're called cytochrome P450, a CYP450, these are 3A4 variations, interact with grapefruit. And you can end up with more of the medication in you if you have it with grapefruit juice, unless you have another med that's also on the same system, and then one is going to overpower the other. Overpower is not the clinical word. I'm just trying to give a good example. Yeah. You'll end up with more of one. But going back to your caffeine, the same thing can happen. Same thing if we take anyone who's on thyroid medication, not all thyroid medications, but levothyroxine. They're always told, take it on an empty stomach first thing when you wake up and then wait 30 to 60 minutes to eat. That's because it interacts. It's more the metal that's in it. It's going to interact with calcium, aluminum, magnesium, iron, and zinc. So we don't want to take a chance if you have any calcium in your breakfast. just take it on an empty stomach to prevent it from interacting. So that's not what to do with pharmacogenetic tests, but caffeine is going to show you on that test result which medication it's going to interact with.
That's pretty crazy. Those are things that you really wouldn't think about. Would you know that without doing that test, or would it be more of like a trial and error thing? Like the person would just drink coffee all the time anyways, and then they're like, oh, I have this weird effect that came up. Or is that something that people get screened for when they get prescribed?
Complete trial and error.
Yeah.
A lot of ADD medications, mental health medications, same way. Let's try one. Let's see how your body reacts. Okay, let's increase the dose. Let's see how your body reacts. It's 6 months. That's not working. Let's try a different one. And this eliminates that lag time. Let's start again with what's the safest and what should be the most effective for you.
That's interesting. So it's like, oh, I drink 6 cups of coffee a day. Well, here's your Adderall.
Yeah.
let me know.
We'll definitely interact there. Let's not do both.
Yeah, for sure. So what got you into looking at more things from this perspective when you're doing this more detailed exam and test and actually checking into genetics? I'm assuming that when you started pharmacy school, you weren't thinking, oh, I'm definitely going to go this route, or I'm going to have a 43-page report that we're going to go through. But I think it's really amazing and detailed. But how are you exposed to that?
So we actually learned about it in pharmacy school.
Really?
It's amazing. And it will tell us, in pharmacy school, we would talk about a class of medication, and then they would say, in this population, I'm going to use the example of clopidogrel. It's a generic name for the brand name Plavix, and it prevents some blood clots from happening, very commonly prescribed. And it's known to be less effective in Pacific Islanders. So the state of Hawaii actually just won a lawsuit against the manufacturer because it was being promoted there just to save. So I think because of that, I'm hoping the manufacturers are going to start, when they do clinical studies, they're going to start looking at these genetic variations and putting it out. And then the doctors who are prescribing the medications are going to know, even without doing that cheek swab, hey, you're at lower risk, like 30% chance this might not work in you. But let's do the cheek swab anyways. Right now, the pharmacogenetic test is more of a reactive situation where I look forward to the day it's proactive. So we know at some point in our lifetime, somebody's going to need surgery, right? We can say, how are you going to respond to anesthesia? Now, the anesthesiologists are phenomenal that I've seen. They can look at the body's response. But if we know propofol is going to be not working, or you might need more, it's going to guide that before you go into the surgery. And same with our opioids. If you're going to have them for recovery, let's choose the right one beforehand, opposed to waiting for a problem and then going, okay, this isn't working. So I think that's where oncology is really steps ahead of the other fields, and they're better at doing genetics and pharmacogenetics ahead of time before they start prescribing medications.
I was thinking, as pharmacists, I'm sure that you get kind of stereotypes of okay, this is what you're going to do as a pharmacist, and probably I'll just say this is what people talk about, and I hear it, and I'm like, oh, you're just counting pills, right? And
count by fives.
Yeah, exactly, right. So it's so much more than that. So I guess what are some common things, or maybe surprising things that people don't know that you're obviously going into detail about what you do in general, but what are things in the pharmacy world that maybe surprise people, or you were surprised about going through school and in your practice in general?
I mentioned how we talked about pharmacogenetics through my pharmacy curriculum. That was just one piece. I talked about the different groups based on where you're from, maybe your race or your location. But we also looked at so much else. We're clinically trained. So we are trained to look at medication therapy management, to look at drug-drug interactions, drug-disease interactions. We then, like I mentioned earlier, many pharmacists go on to do 1 year or 2 year residencies. So you're going to have a specialty and be an oncology pharmacist or a pediatric pharmacist, or, oh my gosh, there's so many different fields, long-term care, compounding, infusion pharmacists. I went into pharmacy school just what you were thinking. I used to work in my dad's store as a teenager. I'm going to go work for one of the big chains. Very happy. I love customer service. I love explaining medications to my patients, making sure they understand their disease states. The interesting thing about pharmacists is we are the most accessible healthcare provider. You can walk into any pharmacy and ask any medication or medical question. And it's amazing what we see, what retail pharmacists will see and do. But we're also trained to a big thing now with COVID, of course, is vaccines. And we've been doing vaccines, I think, for about 20 years now. But we literally stop what we're doing in the retail store so that we can go give you your vaccine. Kind of a crazy setup. And I think things are changing now for pharmacists. You're going to start seeing them in providers' offices working collaboratively. So the doctors, a lot of times they don't have time to go over all the things I just talked about. Especially we have extensive disease states like diabetes, a lot of comorbid disease states. How is your weight management? How's your cholesterol? How is your heart? So much else. How's your back pain, which is when they come to you. And we can look at that and say, okay, maybe there's a non-medication. Maybe you're on too many medications. These medications are interacting. One of the biggest points of medication, I'm going to say mishaps, happens when somebody leaves the hospital. So you'll be put on a medication and then no one ever takes it off. And you're seeing, anyone who's seeing different specialists, nobody's doing that full picture. So to have a pharmacist in that provider's office, they can do pharmacogenetics, they can do a full medication therapy management plan, and that's where the future of pharmacy going as dispensing roles end up being more, I think, with AI and robots and remote verification's really big right now. But I went in everything. You see anything on social media, in movies, on TV, you think pharmacists sit there and count by fives, and that's not at all what we're doing.
Yeah, that's really interesting. But earlier, when you were mentioning about the starting to use some AI to be predictive as far as this, is it to the point when it can know if you have these certain reactions, this gene with these other medications, that maybe this other one would also be something that you would have as well?
Yeah, absolutely. And it's a screening tool. So it's not meant to be just because you have this med and have this genetic variation, you're going to have that reaction. It's not that black and white yet, but it's meant to be used in the bigger picture of how we're going to prescribe.
So then it would take maybe predictions based on that or other data that you already have, and then further keep refining it as you collect more data over time and as like the same medications keep getting reused.
Absolutely. And we can say, hey, we're going to start with a higher dose or we're going to start with a lower dose. Initial prescribing based on those results. That's a good way to put it into practice.
And I know for some medications too that the receptors can be like you can have more or less, and your body can add or take away some depending on like how much of that medicine's in your bloodstream. Is that taken into account too with these kind of tests as far as how fast somebody can maybe to regulate for the medicine?
Well, that's where a pharmacist comes in to look at the whole picture. I'm going to go back to my opioid example. We know with opioids, the reason so many people start them and can't get off is because it upregulates those receptors. You build a tolerance. The more medication you take, the more you're going to need to get the same effect. And that's where a pharmacist can look at the picture and say, you have this genetic variation, you've been on this medication for so long, what's the best way? How can we taper you off the med? How can we get you maybe into physical therapy, start working on your back or whichever part of your body you're using for that pain medication? Maybe there's something else we can do topically. So you're going to get less into that. You're going to get it localized, but less into the bloodstream, working on your respiratory system. There's so many options, and that's where a pharmacist is going to step in and use that clinical knowledge and that training to get the best health of that patient with the least amount of potential adverse effects.
Thinking about the pharmacy and big drug industries and such, there's a lot, I guess, we can break down with this, right? Because it's a big spectrum, and some of your colleagues probably are researching and developing these types of drugs as well. From a clinical standpoint versus the development of drugs, sometimes you probably will see all these ones, I've never heard of that before, or whatever. How do you kind of go about that when there's so much more development of some of new drugs and maybe mishappen drugs, or drugs that you didn't expect to have a good effect on things? Like, so what are things like as a clinical pharmacist, how does that affect your practice when new things come out?
We do have some required CEs, continuing education like every profession does, but it's really, you just have to stay on top of it. So something like diabetes, insulin's been around a very long time. Insulin works very well. So why are pharmaceutical companies coming up with newer, better, more modern medications? And it's going to make it easier. That's the goal. in my opinion. I could be wrong. I need somebody from that type of industry. I work in diagnostics, not in the pharma side of things, but absolutely. When I talked about my role with procalcitonin, my title is as a medical science liaison. The acronym is MSL. And that's what a lot of colleagues with PharmD backgrounds, PharmDs, who are working as MSLs in the pharmaceutical industry and helping with all those clinical studies and bringing products to market, what's going to make your quality of life easier. That's the goal. I got to fact check that with them. But you're right. There's absolutely, and there's so many, like you said, every time you turn the TV on, you're going to see an ad. I graduated with my PharmD 2016. There's a joke that, 3 months later, 6 months later, your knowledge is outdated already because there's already new products coming to market. So decades ago, like I wouldn't say not that long ago, but like through the 80s, the 90s, it was really about these products we talked about. I keep mentioning statins, for example. Well, now we're not doing these products that are like for so many people, but you're getting more specialty medications coming to market. So the diabetes ones, maybe it's something that you're going to inject once a week opposed to multiple times a day. And I don't know if you've heard the phrase monoclonal antibodies. You see those on TV all the time. Those are the new ones. They're NIBs and MABs based on the ending of the word. And they're incredible what they can do. And they make your life easier. And they have a much better effect with least amount of side effects. So not just ease, but safety is the big thing there as well.
How do those function? Those monoclonal antibodies, what do they do?
Without getting into too much science, it's interesting because they're working in your body. So they're working through the immune system. And I wasn't prepared for the question today because it's not my specialty, but every PharmD studies how monoclonal antibodies work. Let me throw a big one out. Everybody talks about with COVID, you can go in, and I think it changes almost daily. I do per diem at a hospital still, and every time I go in, we have new monoclonal antibodies that we're working. But what's so nice about it is if you've been diagnosed and you are at higher risk, but you don't have a severe disease state with COVID yet, you can go into the ER here in Las Vegas. There's a handful of them, and they're going to give you monoclonal antibodies, and it's going to work with the immune system so that it can prevent that infection from taking over and taking holds, and it keeps everything at bay. So that's my non-science without getting too technical into how they work.
Mm-hmm. So would you go ahead and describe what you do for your personal business?
Absolutely. So the title is HG Pharmacist. The HG stands for Hyperemesis Gravidarum. It's a title of a disease state for women with extreme nausea and vomiting during pregnancy. And I don't know if we're getting more awareness of it now or if there's other reasons, like a lot of women go through IVF and then have these higher hormone levels. We don't truly know the cause of it, but we know it's tied into hormones. And I'm a board member with a foundation called the HER Foundation. It's hyperemesis.org. And their scientists there, Dr. Fejdo and Kimber McGibbon, and along with the whole team, discovered a gene called GDF15 that increases vomiting. And it's actually higher in these pregnant women than in patients going through chemotherapy treatments. So the goal now is when somebody becomes pregnant, and their quality of life becomes completely disabled. Their organs start failing. They lose their job. A lot of women, this is happening to, but when they go to seek help, they're told, oh, it's normal. It's okay because you're pregnant. It'll go away at 12 weeks, which it may or may not. It might be 15 weeks, 20 weeks, might last the whole 40 weeks. They're told many things. It's in your mind. I think that stems from Freud, saying, oh, there's other negative thoughts we're harboring onto, or maybe you don't want to be pregnant. A lot of women are told they don't want to be pregnant, which is not the case at all. So what my goal is to make sure these practitioners and the patients know there are medical treatments we can use. The HER Foundation created an algorithm, and it starts with the safest medications, and then you go down the list until you find treatment that's going to decrease that vomiting. Now, the important thing is about nutrition. So it's not just how dehydrated are you? How are you looking at your ketone levels or specific gravity of your urine? Because that's still happening. A lot of women will go to the ER. You don't see an OB until you're probably about 10 weeks along. This can start as soon as you find out you're pregnant. So now you have about 2.5 months of this severe, isolating, debilitating disease state, and they're not taken seriously. So not only am I advocating for these women to have empathy from the providers, but a lot of them they have like mom guilt because they're expecting a glowing pregnancy, or maybe they have other children and it may or may not have happened in a previous pregnancy. So giving them the confidence to go seek help. Everyone right now wants to stay out of an emergency room, of course, but if you're severely dehydrated and malnourished, it's safe for you to go get treatment. The thing is, if you just get normal saline, get an IV and maybe one antiemetic and then get sent home, 24 hours later, you're going to be sent right back to where you were, and it's not good place to be. So my goal then is to, when you go to the ER, just like any other disease state of malnourishment, you want what's called a banana bag. It has high dose thiamine, folic acid, and a multivitamin. You have your electrolytes measured, and if you're depleted, they replenish those. That's your potassium and your magnesium. And I could go on which antiemetics to start from. The problem is, like I said earlier, there's no FDA-approved medications for this disease state. All the medications have pretty severe or potential severe adverse effects. And most of the time, one medication does not work alone or work best. And it's a matter of how much can you take of the medication and still be safe, and for you and for your baby. So it depends how many weeks you are in the pregnancy, what medications I'd recommend, and what other medications you're taking. Much of our population are on mental health medications and then find out they're pregnant. And what I see happening is that obstetricians will say, oh, talk to your psychiatrist or whoever prescribed the mental health meds. And then the psychiatrist will say, oh, go do what your obstetrician said. And these women are just caught in the middle of what we call a hole in healthcare. And nobody's doing medication management early on in the pregnancy. Now, I've seen later in pregnancy, we have phenomenal antepartum care. Unfortunately, if you're going to see a doctor, then you already have complications. So the goal is to look back early in the pregnancy, to start early getting your vitamins. If you can't take a prenatal vitamin, how else can you get thiamine and folic acid and your other vitamins and your other nutrients? And I think I'm one of the few people, I've met a couple other pharmacists that have stepped into this space, but we're just really on our own. There's no actual science here or profession that says, I'm doing this. So one thing I did recently is I got my doula certification, and I am an antepartum doula. This is obviously where my passion is early on, where women just think, oh, this is normal, or they're told it's normal. So we talked about pharmacogenomics or pharmacogenetics. I do that, and then I can create a medication plan for them based on their DNA, and then follow them through the pregnancy, and the goal to get as many nutrients as possible and prevent complications. Crazy, scary statistic right now. The United States has double the maternal mortality rate than any other developed country. Now, a lot of that happens later on due to maybe bleeding or infections, but you have to believe that if we get nutrition early in the pregnancy, then it's going to prevent a lot of these other complications from happening. And you know, there's a new push right now where our government's funding a lot of states. Nevada has right now a maternal, I forget what the title is, but there's a department that was created within our state, not a department, but a committee to investigate why. And we're not one of the more severe states with the high rates, but it is still happening. We're also looking at healthcare disparities in the state of Nevada, and that's where I have this niche I don't know many other people working in, where I can help you figure out what medications are going to be safest for you and your baby. Women that are actually diagnosed with hyperemesis gravidarum, statistic from the Her Foundation said 1 in 3 pregnancies don't make it to term. That's either through miscarriage or through choice termination. None of these women want to terminate. This is not because they just suddenly decided they didn't want to be pregnant. This is because they are literally dying and they're isolated and their mental health is destroyed. I like to look at 3 facets of healthcare. So you have physical health, mental health, and financial health. So that's another area where I can step in and say, okay, the doctor wants to prescribe these, but maybe they're not on your formulary in your insurance. Let's look at financially, how can we get you that medication that would be safest? Especially if anything you take orally comes back up. Let's look at patches. Let's look at IV medications. And because they're all off-label, they're not FDA approved, the pharmaceutical companies are not allowed to talk to the physicians. There's a patch called Sancuso. Its generic name is granisetron. And it works wonders for most of these women, opposed to taking ondansetron so many times, 4 to 6 times a day. Some women, if they have a good provider, will set them up with home health and get what we call an ondansetron azopram pump. But it's subcutaneous, and they're injecting themselves all day long, and it's not fun. So, and it's financially could be devastating depending what your insurance you're on. But there's actually even like IV backpacks they can take and still go to work. So many women are just staying home and suffering and don't know these treatments are available for them, and that's what my business does.
It's a lot to unpack.
It was a long-winded.
Yeah, but
sorry.
It's great. It's great. There's a lot of great information there. One question I would like to kind of figure out is morning sickness and, overall nausea, vomiting, you would just associate with I'm pregnant, right? So how do you differentiate what if you actually have the disease versus this is just a normal process of pregnancy?
Excellent question. My first thing is what's going on with your quality of life and how long is it lasting? But we have actual lab tests that can tell. One is weight loss. If you're losing 2 pounds a week or more than 5% of your pre-pregnancy weight, we're going to look into this more. I mentioned looking at ketones in your urine. Now your body's breaking down its reserves, and we don't want that to happen. We're going to look at electrolyte abnormalities. We're going to look at, again, I want to go back to your quality of life. Are you able to do basic standards of care? When you can't get out of your bed to go to the bathroom, when you can't shower, when you can't brush your teeth, we know you're in a severe disease state. How's your mental health impacted with this? When everyone, I think in movies, this obviously happened to me, when I first became pregnant, I saw a woman would maybe, get sick in the beginning of a pregnancy once or twice, and then they glow the rest of the time. That's what we see in movies. And we have a lot of movie stars now filming, reality TV, their whole pregnancy, and you don't see this. Princess Kate, though, Amy Schumer, we have more well-known names now that it's happened to and they're speaking out. And there's a lot of treatments that Amy Schumer spoke about using CBD. We don't have any clinical studies, so we're just advocating if anyone has the resources to fund any of these studies, the Her Foundation is doing them, but there's so much more that we can do. So what I look is on our guidelines, what's the safest, when to stop the ones that aren't working, and then to go down the line. And eventually we have second line, we have third line, and then we have experimental meds. But that's where I think a lot of women are not getting diagnosed correctly. I'm going to step back again and say, okay, you become pregnant, and then you go, this is happening. You don't have an OB yet, you haven't seen, or they won't fit you in. With COVID, it's even more difficult to get into providers. Not a lot of telemedicine in the maternal health world just yet because most doctors want to do a physical exam on the mom. And so that's where we're going to look at and say, okay, they're going to go to an emergency room. Well, emergency room doctors are phenomenal at acute care. Their goal is to treat you and get you back home. One of the hospitals where I work does have a hospitalist in OB, obstetrical hospitalist. Is that the right phrase? And then, so they'll just determine, they're going to rule out, is this caused from Hyperemesis Gravidarum, or is there something else causing this disease state? So that's something important because there are a lot of other things that can cause that as well. When they rule out everything else, then they'll decide if you go home or if you're going to be admitted into the hospital. Ideally, you can go home, but you want to make sure you have a plan of care. I think a lot of people just aren't diagnosed properly. So it's stated it's a rare disease, anywhere from 0.5 to 3% of our population. But if you look at the number of pregnant women in the United States on an annual basis, like 2% of that, you're looking about 75,000 women. And that's too many to leave suffering or told it's normal, and the complications are vast from it. I'm part of a foundation, part of the Her Foundation, a campaign called One Mom is Too Many, based on, in memory of a woman named Maria who died from Wernicke's encephalopathy. Now, we know Wernicke's from alcoholics. Every alcoholic that comes into the emergency room, automatically get them a banana bag with high-dose thiamine. That's my goal for all these pregnant women. As soon as you go to the ER, let's get you. We know thiamine gets depleted in about 2 weeks of time. A lot of women, they're waiting because they go, oh, this is a normal part of pregnancy. May or may not be. And that's where you want to look at all those. Let's check those boxes. The best website for this is hyperemesis.org. Has all the tools for you where you can see, do you have morning sickness or is it hyperemesis? And if it is hyperemesis, where are you? Is it mild, moderate, or severe? And the goal is just to prevent it from getting to any severe state.
Very cool. And if people want to reach out to you, how would they be able to find you?
So online and social media, I'm at HG Pharmacist. I'm online at hgpharmacist.com. And email info@hgpharmacist.com. You can find me on LinkedIn as well. I'm Danielle Raiman Plumber. And I have a workshop coming up I'm super excited about. I put it on Eventbrite. I'm going to be sending out to my email list and posting on social media as well. I'll be doing monthly how to create a medication plan to treat nausea and vomiting in pregnancy, anywhere from morning sickness to Hyperemesis Gravidarum. And again, these are the people who are told, try crackers, try ginger, and it does not work at all. So now what do we do? And that's where I'm going to come in and help. And then later this year, I'll be launching a course. So keep your eye out for that.
Excellent. Well, really appreciate your time. Appreciate you being on the show. I feel like we learned a lot.
Oh, absolutely. Thank you.
You two are absolutely amazing. And I learned also, recently we were talking about Antoinette, if you are stuck in bed due to your electrolyte abnormalities, your weakness, or other maternal disease state, there are exercises you can do to keep those muscles strong. So thank you for educating me about that as well.
Oh, absolutely.
Thank you.
Thank you.
You're welcome. Thank you.
We'd like to thank you for listening to La Vida Las Vegas podcast. We hope you enjoyed the time with our guests as much as we did. It would help us out so much if you could share, subscribe, or review our podcast or any combination of the three. Thanks again, and remember to take care of yourself.